The reasons for the transesophageal echo, or TEE study, and any prior imaging studies are reviewed prior to the procedure. In addition, evaluation of the patient's risk for the TEE procedure and moderate sedation is performed based on the clinical history and a focused physical examination. In high-risk patients, supervision by an anesthesiologist is recommended. After this evaluation and discussion with the patient, informed consent for sedation and the TEE procedure is obtained. The final patient check is performed along with a quick review with the nurse and sonographer of the patient's clinical diagnosis, the goals of the TEE study, and any special considerations for ensuring procedural safety. Patient monitoring is set up with the nurse placing a blood pressure cuff, oxygen saturation monitor, and ECG leads, with recording of baseline data. The oral suction system is set up to allow control of secretions during the procedure as needed. A nasal oxygen cannula is set up as well. The equipment needed for the procedure includes a tongue depressor, lidocaine for local pharyngeal anesthesia, and a bite block for insertion of the probe. The probe is examined to ensure that the probe length is intact and to test the motion of the probe in both directions. The electronic rotation of the image plane also is checked before probe insertion. During the exam, instrument parameters are adjusted as needed for optimal image and Doppler data recording. The patient is positioned on the left side to reduce the risk of aspiration, in addition to being NPO for several hours prior to the procedure. The physician who inserts and manipulates the TEE probe uses universal precautions with non-sterile protective measures, including a mask, eye protection, gown, and gloves. Local anesthesia of pharynx is provided by gently spraying small amounts of lidocaine, using a tongue depressor for better visualization. Sedation is provided in gradual, incremental doses using the institutional moderate sedation protocol. The goal is for the patient to be comfortable and relaxed, but awake so he can cooperate with the procedure. A bite block is gently placed between the teeth, ensuring it is centered and comfortable for the patient. There are several approaches to placing the probe in the esophagus. My preference is ask the patient to put his chin on his chest, then place the lubricated TEE probe in the bite block with my left index finger along the side of the bite block. The probe is advanced slightly and then directed inferiorly with my finger, centered in the posterior pharynx. When gentle resistance at the upper esophageal sphincter is encountered, the patient is asked to swallow and the probe advanced as the sphincter relaxes. The probe is advanced to the level of the left atrium as higher probe positions may be uncomfortable. Once the probe is in position, a systematic sequence of images is recorded to ensure a complete examination of all 4 cardiac chambers, all 4 valves, the systemic and pulmonary venous connections to the atria, and the proximal segments of the aorta and pulmonary artery. We start in a high esophageal 4-chamber view at 0 degrees rotation, with a depth setting that includes the entire left and right ventricles, taking care to angulate the plane to avoid foreshortening of the apex. The LV apex is centered and the image plane rotated to 60 degrees, which provides a 2-chamber image plane. Slight lateral rotation and adjustment of angulation may be needed to optimize this view. With the apex again centered, the image plane is rotated to about 120 degrees to obtain a long axis view. Again, adjustment of probe position and angulation may be needed to optimize the long axis plane. In the correct image plane, the aortic valve leaflet should appear linear with central closure. The mitral leaflets are clearly seen, and the left ventricular chamber is in a long axis plane. These 3 views are useful for evaluation of LV size, global and regional function, RV size and systolic function, and left and right atrial size. While maintaining the long axis plane, the sonographer adjusts the depth and transducer frequency on instrument control panel to focus on the mitral valve. The mitral valve is centered in the image plane, and the image plane is slowly rotated from 120 to 0 degrees, using 2D imaging to show mitral valve anatomy, with images recorded in standard long axis, 90-degree, 2-chamber, and 4-chamber views. After adjusting the sector width, color Doppler then is used to examine for mitral regurgitation while rotating back from the 4-chamber view to the long axis view with recordings in the standard image planes. This patient has a small amount of mitral regurgitation. We can zoom on the mitral valve to look at the proximal jet geometry. This patient has a very narrow vena contracta, only 1 or 2 millimeters, so further quantitation is not needed. The mitral valve can also be examined with 3D imaging. First, the valve is centered and a region of interest defined. Then real-time 3D images are obtained with the view rotated to show the valve from the left atrial perspective. With real-time 3D imaging, the TEE probe position can be adjusted while viewing the 3D valve anatomy. A full volume acquisition merges image data from several beats to provide improved resolution and the ability to manipulate the image data after acquisition to show the mitral valve from the left atrial side and from the left ventricular side. Next, attention is turned to the aortic valve and sinuses. First, the transducer moved up in the esophagus to see as much of the ascending aorta as possible. Then the aortic valve centered in the image for both 2D and color Doppler imaging. Here we see just trace regurgitation of a slightly sclerotic valve. Because the aortic valve is not axially symmetric with respect to the T probe position, we cannot do a full rotational scan as for the mitral valve. Instead, the image plane is rotated to about 35 to 40 degrees, which provides a short axis view of the valve, allowing identification of the number of leaflets as well as calcification and so on. The left main coronary may be visualized just superior to this image plane. In some patients, the right coronary ostium also may be seen. Going back to the 4-chamber plane at 0 degrees, depth is adjusted to focus on the left atrium and atrial appendage. The atrial appendage can be easily visualized at 0 degrees by slight withdrawal and angulation of the image plane. A high transducer frequency, typically 7 MHz, and resolution or zoom mode is used to examine carefully for atrial appendage thrombus. The appendage is visualized in at least 2 orthogonal views. My preference is to center the appendage in the image and do a rotational scan from the 4-chamber plane to the 2-chamber plane. Using Doppler to record atrial appendage flow also is helpful. In sinus rhythm with the sample volume about 1 centimeter into the appendage, an atrial contraction velocity greater than 0.4 centimeters per second towards the transducer is seen. The pulmonary veins are most easily visualized using 2D and color Doppler, with the aliasing velocity lowered to about 30 to 40 centimeters per second to show the low flows in the veins and left atrium. We start with the left superior pulmonary vein, which is adjacent to the appendage, and record color Doppler to show position, and then pulsed Doppler for evaluation of filling velocities. Advancing the probe slightly, the more horizontal left inferior pulmonary vein comes into view. Turning the image plane towards the patient's right shows the right superior and inferior pulmonary veins, again identified with slight superior and inferior adjustment of the image plane. The pulmonary veins also can be imaged with the image plane rotated to 90 degrees. In these views, the superior vein is on the right side of the screen. Attention is next turned towards the atrial septum. My approach is to adjust depth and sector width in the 4-chamber image plane, and then center the atrial septum to show the fossa ovalis. Once centered, the entire septum can be examined with 2D imaging by rotating the image plane from the 4-chamber to long axis plane, keeping the septum in the view. 3D imaging also can be useful for examination of the atrial septum on TEE. In the bicaval view at 90 degrees, we see the superior and inferior vena cava. With color Doppler, we can examine for a patent foramen ovale as the image plane is rotated back to 0 degrees. If there is clinical concern for a septal defect or PFO, a saline contrast study may be appropriate as shown here with Valsalva maneuver. Next, we look at the right ventricle and tricuspid valve in a 4-chamber view with the right ventricle centered in the image. Color Doppler allows evaluation for tricuspid regurgitation, which is minimal in this patient. The pulmonic valve is seen in a 90-degree view distal to the aortic valve on 2D and color flow imaging. The probe is then advanced into the stomach, with slight resistance at the gastroesophageal junction. The transducer frequency is lowered and depth adjusted to obtain a short axis view of the left ventricle. If air obscures the ultrasound image, slight repositioning may be needed. With rotation of the image plane to 90 degrees, a 2-chamber view of the mitral valve and left ventricle shows details of the chordal apparatus. The exam is completed by turning the image plane posteriorly to view the descending thoracic aorta. The aorta is imaged continuously in short axis as the probe is withdrawn along the length of the esophagus with color imaging and rotation into a long axis view as needed. Before removing the probe, it is prudent to check with the sonographer and nurse if any views have not been recorded. Once imaging is complete, the probe is gently removed under direct vision and the bite block removed. The nurse provides oral suction if needed. The probe is placed in a bag for cleaning. Monitoring is continued after the procedure based on institutional guidelines for sedation. The patient is then discharged home with a companion or family member.